Namaste, हमेशा खुश रहो बेटियां. I am Dr. SUMAN, Assistant Professor, KAYACHIKITSA Department, Faculty of Ayurvedic Science, Jayoti Vidyapeeth Women's University. Today in this session, I am going to discuss my lecture number 3 on diabetes mellitus. In this part, I'll discuss investigations and some of the non-pharmacological management part of the diabetes mellitus. So let me share a PowerPoint presentation for you people for your better understanding, so that we can understand all the points one by one. So investigations of diabetes mellitus, number one is urine glucose. Although this is not a confirmatory test for the diabetes mellitus, but still it is useful and it is done by dipsticks and it's a screening procedure for detecting diabetes. If possible, testing should be performed on urine past 1 to 2 hours after a meals to maximize sensitivity. There are some of the investigation, there are some of the disadvantages. That's why it is not considered as a confirmatory test for the diagnosis of diabetes mellitus. Individual variation in renal threshold for glucose, which is common during pregnancy and in young people. And some of the drugs which interfere with the urine glucose tests are beta-lactam antibiotic, levodopa, and the salicylase. So these, because of these disadvantages, it is not considered as the confirmatory test for the diagnosis of diabetes mellitus. Next important test is blood glucose. So laboratory glucose testing in blood relies on an enzymatic reaction, that is glucose oxidase, and it's a cheap, usually automated, and highly reliable. So glucose concentration are lower in venous than arterial and the capillary blood. So venous plasma values are usually the most reliable diagnostic purposes. So now diabetes, what are the confirmation criteria? What are the levels of the plasma glucose when we can diagnose a person as having diabetes mellitus? So the criteria are either plasma glucose in random sample or 2 hours after 75 glucose given orally. That is called as 75 glucose load. Then the blood sugar level is more than equal to 11.1 millimole per liter, equal to 200 milligram per deciliter. Or next criteria is fasting plasma glucose more than equal to 7 millimole per liter, 126 milligram per deciliter. Or next criteria is HbA1c equal to more than 48 millimole per mole, and in asymptomatic patients. Two diagnostic tests are required to confirm diabetes. The second test should be the same as the first one to avoid the confusion. Now there is a one stage that is pre-diabetic. So it is classified as impaired fasting glucose, that equal to fasting plasma glucose, that is more than equal to 6.1 millimole per liter, that is 100 milligram per deciliter, and less than 7.0 millimole per liter, that is 126 milligram per deciliter. Means between 100 milligram per deciliter to 126 milligram per deciliter blood sugar level is considered as impaired fasting glucose. So next is impaired glucose tolerance, IGT. This is also pre-diabetic condition. In this condition, fasting plasma glucose is less than 126 milligram, and 2-hour glucose after giving 75 gram oral glucose drink, it is 140 to 200 milligram per deciliter. So these are the criteria for the impaired glucose tolerance. Now next test is urine and blood ketones, that is presence of ketones in the urine and the blood. So acetoacetate can be identified in the urine. So these are the ketone bodies. Acetoacetate, it can be identified in urine by nitroprusside reaction using either tablets or dipsticks. Ketonuria may be found in normal fasting people or doing persons who are doing strenuous exercise or who are vomiting repeatedly and eating a high fat diet and low in carbohydrate. That's why ketonuria is not a pathognomic of diabetes, but if it is associated with glycosuria, the diagnosis of diabetes is highly likely, but it should be confirmed with the blood glucose levels. Now, how to interpret the capillary blood ketone measurements? So, if the ketone levels are less than 0.6 millimole, it's a normal, no action is required. If they are between 0.6 to 1.5, this suggests deteriorating metabolic control, and the patient should continue to monitor and seek medical advice if this level gets sustained or progressive. Between 1.5 to 3.0 with high blood glucose level, that's more than 10 millimole per liter, it means there is a high risk of diabetes ketoacidosis and the patient should seek medical advice. And when it is more than 3.0, it's a condition of severe acidosis, severe ketosis, and it is associated with the high blood sugar level that suggests presence of diabetic ketoacidosis and seek urgent medical help. Now, next is glycated hemoglobin. It's a very important test, and it is very common nowadays. Glycated hemoglobin provides an accurate and objective measurement of glycemic control over a period of weeks to months. So, with the level of glycated hemoglobin, it can be known about the glycemic control over periods of weeks to months. In diabetes, the slow non-enzymatic covalent attachment of glucose to hemoglobin, that is called as glycation. That's why it is called as glycated hemoglobin. So that increases the amount in the HbA1c or HbA1 fraction related to non-glycated adult hemoglobin HbA0. The laboratories may report glycated hemoglobin as total glycated hemoglobin, GHB, or HbA1c or HbA1. So in most of the countries, HbA1c is the most preferred measurement. Now, the rate of formation of HbA1c is directly proportional to the ambient blood glucose concentration. So a rise of 11 millimole per mole of HbA1c corresponds to the approximate average increase of the 36 milligram per deciliter of the blood glucose. Although HbA1c concentration reflects the integrated blood glucose control over the lifespan of erythrocyte, that is 120 days, HbA1c is the most sensitive to changes in glycemic control during in the time of the month. So this is all about the glycated hemoglobin. The next is islet autoantibodies. As type 1 diabetes is characterized by the autoimmune destruction of the pancreatic beta cells. It can be useful to establish evidence of such an autoimmune process. As we know that diabetes type 1 is due to autoimmune reaction, so islet autoantibodies can be a very good measurement for the differential diagnosis between type 1 and type 2. So if these autoantibodies are present at high titer, this can be supportive of the diagnosis of type 1 diabetes, and these antibodies are measured directed against components of the islet and consist of antibodies to insulin, glutamic acid, and decarboxylase, protein tyrosine phosphatase related protein, that is IA2, and the zinc transport, that is ZNT8 diabetes. So some laboratories now they have included anti-ZNT8 antibodies in the panel of the test, which increases the sensitivity for the type 1 diabetes to 92%. Next important investigation is C-peptide. C-peptide can help clarify the differential diagnosis of diabetes. So it is usually very low in long-standing type of diabetes, type 1 diabetes, and very high in severe insulin resistance. So C-peptides gets increased in type 2 diabetes, and they are usually very low in long-standing type 1 diabetes. Next important test is urine protein. So if there is a passage of protein in the urine, it clearly indicates that there is some abnormality in the kidney. So it indicates nephropathy. So standard urine dipstick testing for albumin detects urinary albumin at concentration above 300 mg per deciliter. But small amount of protein, smaller proteins, that's microalbuminuria, they can only be diagnosed by using specific albumin stick or by quantitative biochemical laboratory test. Microalbuminuria or proteinuria, that is presence of in the urine in the absence of an urinary tract infection. It is an important indicator of nephropathy and or increased risk of macrovascular disease. These are the macrovascular disease, is complication of the diabetes mellitus. Now, how to manage diabetes mellitus? What are the aims of the management of diabetes mellitus? Aims are to improve symptoms of hyperglycemia and minimize the risk of long-term microvascular and macrovascular complications. So treatment methods for diabetes include dietary, lifestyle modifications, oral anti-diabetic drugs, and injected therapies. So in patients with suspected type 1 diabetes, urgent treatment with insulin is required and prompt referral to a specialist is usually needed. While in patients of suspected type 2 diabetes, the first approach of the management is to advise about dietary and lifestyle modifications. Oral anti-diabetic drugs are usually added to those who do not achieve glycemic targets or who have symptoms of hyperglycemia at the diagnosis and they have a very high HbA1c. So patients with type 2 diabetes who are present with marked symptomatic hyperglycemia or diabetic ketoacidosis will require initial management with insulin treatment. So these were the goals of the treatment of management of diabetes mellitus. Now there is a very important point, that is self-assessment of glycemic control. Why this self-assessment of blood glucose level is important. So in people with type 2 diabetes, there is not usually a need for a regular self-assessment of blood glucose unless they are treated with insulin. So or at the risk of hypoglycemia, like while they are taking sulfonylurea. So if we are taking insulin, they are taking sulfonylureas, or both these conditions makes the patient prone to hypoglycemia. In that condition, self-assessment is needed in type 2 patients. Insulin-treated patients should be taught how to monitor their own blood glucose using capillary blood glucose meter. And immediate knowledge of blood glucose levels can be used patient to guide their insulin dosing and to manage exercise and illness. Now, what are the therapeutic goals? So, with the management, goals have we? What goals physician has to achieve? So, early on in diabetes, that is patient managed by diet or one or two anti-diabetic agents. A target of 48 millimole per mole or less may be appropriate. However, higher target of 58 millimole per mole may be more appropriate for the chronic patient, for the old patient, or the patient with pre-existing cardiovascular disease, or those who are being treated with insulin, because they are at the risk of hypoglycemia. So for them, the target of HbA1c is slightly more than the early diabetic patient, that is 58 millimole per mole. In general, the benefits of the lower target HbA1c that need to be weighed against the increased risks of the higher level, against an increased risk, that is risk of hypoglycemia in the insulin treated patients. So type 2 diabetes is usually a progressive condition. There are diet and lifestyle changes, so that there is usually a need to increase diabetes medication over time to achieve the individualized target HbA1c. The target for blood pressure is usually 140 upon 80 mm of Hg, although some guidelines suggest 130 30 upon 80 mm of Hg. For lipid lowering agents, there is a reduction in cardiovascular risk even with normal cholesterol levels. If the statin therapy is usually recommended when the 10-year cardiovascular event risk is at least 20%. As a rule, anyone with type 2 diabetes who is over the age of 40 should receive a statin irrespective of the baseline cholesterol levels. Now, for the management of diabetes mellitus, what is the role of patient education, diet, and lifestyle? So, aims of the dietary management are to achieve good glycemic control, to reduce hyperglycemia and avoid hypoglycemia. And that weight management is very important, and that will be assisted with weight maintenance for type 1 diabetes, non-obese type 2 diabetes, and weight loss for overweight and obese type 2 diabetes. And now to reduce, the treatment should be done to reduce the both kind of complications, that is micro and macrovascular complications, to ensure adequate nutritional intake. And patient has to avoid atherogenic diets, so those that aggravate complication, for example, high protein intake in nephropathy. Now, dietary constituents and recommended percentage of energy intake. So, carbohydrate should be 50%, in that sucrose up to 10%. If you see the fat, total fat should be less than 35%, in that N6 polysaturated should be less than 10%, and N3 polysaturated that should be N3 polysaturated, in that portion 140 gram oily fish once or twice weekly is sufficient. Monosaturated 10 to 20% and saturated less than 10%. Now we see the protein levels that should be 10 to 15%, should not exceed 1 gram per kg of the body weight per day. And there should be 5 servings, 5 portions of fruits and vegetables daily. So this is about the diet management. Now weight management is important, as type 2 diabetic patients, they are overweight or obese, and with some anti-diabetic drugs, including insulin. The patient gets a weight gain. So in that, weight management is important. Obesity, particularly central obesity with increased waist circumference, also predict insulin resistance and cardiovascular risk. Weight loss can be achieved through a reduction in energy intake and an increase in energy expenditure. Through physical activity, lifestyle interventions, or pharmacotherapy for obesity, which associated with weight reduction and have a beneficial effect on HbA1c. But long-term benefits in the term of glycemic control and macrovascular disease, they are not adequately assessed. More recently, bariatric surgery has been shown to induce marked weight loss in obese individuals with type 2 diabetes, and this is often associated with significant improvement with HbA1c and withdrawal or reduction in the diabetic medication. Now, exercise has its own unique role. So all patients with diabetes mellitus, they should be advised to achieve significant level of regular physical activity. This can include activities such as walking, gardening, swimming, and cycling. A supervised and structured exercise program may be helpful in the patients of type 2 diabetes. Patients with type 1 diabetes, they appear to do exercise less frequently because they are scared of hypoglycemia, or they find difficulties in managing insulin levels around exercise. So for that, the health benefits of exercise are equally important in type 1 diabetes. So this should be addressed in the clinic, and specialist advice should be sought on the insulin carbohydrate management alone during and after the exercise. Now, alcohol is recognized as having both beneficial and harmful effects on the cardiovascular disease, and this also appears to apply in patients with diabetes. Alcohol can therefore be taken in moderation in diabetes with the aim of keeping the national guidelines related to the recommendation for people without diabetes. For example, in the UK, the weekly recommended maximum is 14 units for men and women. So, however, alcohol can reduce hypoglycemia awareness, and by suppressing gluconeogenesis, increase hypoglycemia risk. And this particularly occurs in fasting states. So, the people with diabetes mellitus who drink should be advised to eat at the same time. Now, Ramadan. So Ramadan is a very important phase, is a festival kind of phase before Eid for the Muslims, and they fast for the whole month from the morning to evening, that is sunrise to sunset. That one month of fasting is called as Ramadan. So diabetic peoples are recognized as the exception to this, and they are not required to fast. Many will choose to do so. But in this context, patient education, regular glucose monitoring, and the adjustment of the treatment regimens who are on sulfonylureas and insulin, because in both two conditions there is a risk of hypoglycemia. So adjustment of the treatment regimen should be are essential and should occur weeks prior to the Ramadan. So prior to the Ramadan, that dose adjustment and the treatment adjustment and the substitute of the medicine, hypoglycemia causing medicine, that should be done. Diabetic therapies that do not cause hypoglycemia may prove safest during Ramadan if glycemic control permits. So DPP-4 inhibitors or GLP-1 receptor agonists may be especially useful because their effect on insulin secretion is glucose dependent. So these medications can be helpful in the time of Ramadan. So this was all about the investigation and the non-pharmacological treatment part of the diabetes mellitus. In the next lecture, we will take the pharmacological treatment part of the diabetes mellitus. So I hope you will be satisfied with this session. This session is powered by digital version 2.0 Jayoti Vidyapeeth Women's University. If you have any queries, any doubts, please write in the comment box. I will resolve it. Thank you very much for watching this video.